Good afternoon, everyone. So in the name of Auxin Surgery, I would like to warmly welcome all of you at this webinar on the experience of the use of the CADISS, a solution for fibrosis in spine revision surgery. My name is Valerie Gordon. I'm the Chief Scientific Officer of Auxin Surgery, and I'm pleased to introduce our today's speaker, Dr. Michel Triffaux. Dr. Triffaux is a neurosurgeon, coordinator of the spine unit of the Centre Hospitalier Wallonie-Picard in Belgium. Dr. Triffaux is a member of a different professional organization, and in the past 25 years, he performed more than 5,000 spinal surgeries. The content of this webinar will be shared in three sections. I will start by a quick introduction of the CADISS system and its mechanism of action. And afterwards, Dr. Triffaux will present his expertise with the CADISS system and its pharmacoeconomic evaluation in spine revision surgery. Last but not least, you will have as well the opportunity to ask questions via the Q&A or discussion buttons. And of course, the webinar will be recorded for you and other of your colleagues to review it later on. Okay, so the CADISS system is a combination of chemically active drug substance, the MESNA drug substance, and a non-cutting dissector. The dissector is irrigated to allow the instillation at the site of dissection of this drug substance. The CADISS system is a safe device. It is clinically validated, and this device has a quick learning curve. The CADISS system, the CADISS name is used for chemically assisted dissection. So the MESNA is a well-known and safe drug substance. It has been used for more than 20 years as a mucolytic and uroprotectors. The MESNA solution, the MESNA is a synthetic thiol compound, and it acts by disrupting disulfide bonds. Disulfide bonds are responsible of the tertiary structure of the fibrous protein, the collagen protein, which are present at the cleavage plane and in the adherences between the healthy tissues and the pathological tissue. Auxin Surgery has developed a specific MESNA solution for surgical application and for topical application at the site of action and at the surgical field. Okay, so the proof of principle of this chemically assisted dissection has been largely established in a large number of applications. So, for instance, in chronic otitis, in rhinoseptoplasty, in spine revision, esophageal cancer, cholecystectomy, endometriotic cyst, and prostatectomy. All the data of randomized clinical trials have been published, and we have collected more than 1,000 patients in all these randomized clinical trials, was 50% are under MESNA application and CADISS application. From these randomized clinical trials, we have established the usefulness of the CADISS system, and we have three main benefits of using the CADISS system. The first one being the selective weakening of the adherences. And so the CADISS reduces the mechanical forces needed to separate tissues. It's as well reduced the side effect because of the preservation of the surrounding tissue during the dissection. And it reduces as well the relapses because it allowed the full removal of the pathological tissue. The CADISS system is a CE class 3 medical device. The device is registered in Europe for two main indications, hair surgery and musculoskeletal surgery. In the musculoskeletal application, we can identify three main applications. The first one being the removal of the fibrosis resulting from previous surgery or from trauma, and it's the case, for instance, in revision spine surgery. The second application is idiopathic post-traumatic or post-operative perineural fibrosis, and a specific application in Dupuytren's disease in the hand surgery. And the third application is tendon adherences. The product portfolio of Auxin surgery. So we have two main systems. One is a manual kit and the other one is the remote kit. So basically both systems have the same components. We have a cartridge which allows the reconstitution of the Mesna solution. So the Mesna powder is stored in the upper part of the cartridge and the solution in the lower part. And by a very simple mechanism of reconstitution, you get the Mesna solution. Then this cartridge is connected to the irrigated instrument by a specific tubing. And in terms of dispensing mechanisms, in the manual kit, we have a manual dispenser, which is controlled by the thumb. And in the remote system, the dispensing mechanism is controlled by the foot. We have as well a set of instruments which present exactly the same design as the instrument you are used to use in your specific application. We have just adapted those instruments to allow the irrigation and the installation of the Mesna solution at the distal end of this instrument. So now I would like to leave the floor to Dr. Triffaux for the presentation of his expertise in the spine revision surgery.
Hello, everybody. Thanks you, Valerie, for your introduction and your presentation. Spinal revision remains a real challenge. It's a complex surgery and often ungrateful. And spine surgery, it's a succession of small details, and the good results are not always there, or unfortunately. It's more important to have a good pre-op evaluation, and it's possible to change the approach to avoid passing through the fibrosis. When the previous approach is posterior, you choose another approach by an anterior way or lateral way, but it's not always possible. Avoid to tear off because you can make accidental dualities, and it's possible to have a product to dissolve the fibrosis. Take it. We had the opportunity to test the CADISS for 10 consecutive cases. This is the design of the study with previous data for infiltration surgery, evaluation of the percentage of the fibrosis, and the topography at the end, the feeling of the surgeon. This is the study with the first 10 cases. Now we had about 20 cases after 1 year. You have the different localization, one cervical level, the different data, and the efficacy and the feeling of the surgeons. It's 10 for the 10 first case. Now, I will show you the first case. It's an ideal case to start. It's a revision in a posterior interbody fusion to the late recurrent disc hernia. And I decided to do a double TLIF in L4, L5, and L5, S1. This is a video. You can see the interlamar view with lamina L5 and S1 here. And with a lexical ronger, I remove a maximum of fibrosis. After, I instill the mesna with a cannulate dissector, and it's important to take the time to work the mesna. Now, after I put the screw, and now I make the dissection of the bone and the canal with the ronger, Carrison ronger. Now you can see the opposite side with no fibrosis and the right side with an important fibrosis. I use the hook between the fibrosis and the dura mater and resect with the Carrison ronger the epidural fibrosis. And if necessary, I put again the cannula dissector and the mesna in the field. And dissection plan is possible between the dura and the fibrosis. And with a microcoagulator, I cut the fibrosis, and I have the protection of the dissector behind the fibrosis. And after, I can see the road S1 and the space of the disc to make my dissectomy. Now, if you are not confined to try, you can try the mesna on implant. This is a revision case operate in other departments, but you have a losing of the inferior screw, and if you put the mesna on the implant, you can see very well the plane to the dissection between fibrosis and the head of the screw. Another case is a usual case. It's a recurrent lumbar disc hernia. A young woman, 36-year-old, and 3 years ago have a surgical cure of lumbar disc hernia. Now, 3 years after, she presents left radical AG, improved with the conservative treatment, but still a right S1 radical AG increases with failure of conservative treatment. This is a CT scan with disc hernia on the right road, S1, and the other side. And this is MRI. It's the same, but you can see disc hernia on the left side or the opposite side on and the right recurrent hernia. What's the best approach? a new discectomy or sequestromy versus a fusion. But there are no consensus for the best choice. In my mind, before I can use the CADISS, for a recurrent disc hernia on the same level, on the same side, I make a fusion with a transforaminal interbody fusion. But in this case, for a young woman with a discopathy upper, I prefer to make only a sequestromy and no fusion in L5S1 and no fusion of L4, L5, L5, L S1. This is a view of the operative field with fibrosis in interlamellar space. Now you can see the growth of S1, and behind you can see the disc hernia. A short video of the surgery. When it's possible to use the CADISS, you use the CADISS. It's the first time. After to put the retractor a second time, and now a third use of the CADISS. It's important to give the time for the CADISS can work. It's you see the lamina, and now the fibrosis interlamellar, and with the dissector I keep the bone contact lateral to remove fibrosis with Lexkel rongeur, and with the Kerrison to resect the inferior part of the L5 lamina, and to see now the root of S1 with the hook, and behind S1 you can see the hernia, and only sequestromy without dissectomy, without fusion. Yes, for the last case is a bad case with a recurrent spinal stenosis after 3 previous surgery. It's an old man with more comorbidity with 3 previous surgery. And I see for the first time the patient in 2021 with a Neurosurgeon publication. This is a CT scan, and you can see more level degenerative aspect in the disc and the facet, and a reduction of the canal with the thickness bone of the lamina regrowth after previous surgery. This is a view of operative field with the very big lamina, and during the decompression with the bone scalpel, the situation. Now, this is a post-operative CT scan with decompression of the canal and fixation. The surgery is in 2 steps. First, direct lateral interbody fusion in L2, L3, L3, L4, and a second step with decompression and fixation. But at each level, I have dural tears because in this situation, the mesna can stay on the fibrosis between the bone and the epidural fibrosis. But the evolution after surgery for the patient is good. It's a principle. Economic study of the additional cost of the direct additional cost of the dural tears. This study on the hospital bill is very easy to consult and to have the data of the 10 consecutive cases. In the population is we have 3 revision, 1 trauma, and the 3 surgeon of the department participate at this study, Dr. Bourras and Dr. Lundvik. Now, if you see the cost, the additional cost, first, the extra timing for the reparation of the tears, 20, an average of 20 minutes per dural tears at 10 euro minutes. It's extra cost of 200 euro. After the suture and the different product to close the dura, and you can use a sealant, T-seal, or the different patch of hemostatic agent like Tacosi. And this is the cost for each case. And the extra stay, the longer stay, it's 1 or 2 days. It's the cost per days in our hospital. And the total, it's 1,348 euro by dural tears. It's important when I discuss with the pharmacy on the administration of my hospital, because in Belgium the CADISS is a charge only for the hospital, not the patient, not the assurance, only the hospital, and the cost, it's about 2 or 3 thousand euro. And it's an important point to discuss to obtain the product in our hospital. Now, the conclusion is the take-home message. It's to first, you must to minimize the thickness of the epidural fibrosis with a less scale rongeur. 2, it's more important, take the time for the product to work, and at the end wash the operative area with the physiologic liquid. And the outcome is to reduce the operating time, to reduce accidental dural tears, and reduce the bleeding, and at the end to reduce the light of hospital stay. And it's not a miracle product. It's the same as hemostatic agent. you always need to do a good hemostasis. And in this situation, a careful dissection always be done.
Thanks a lot, Dr. Triffaux, for this presentation and the presentation of your experience with the CADISS system. So we can now switch to the list of questions. So we have received several questions from the attendees. So regarding the first questions, how can we, so it's more a general question which has been asked before the presentation, but perhaps you can quickly summarize. So the first question is how we can remove adhesion safely in a reduced spine case. So meaning that it was more or less the topics of the discussion of today. And so if you would advise surgeons to use the CADISS system, in which type of revision spine cases would you advise to use the CADISS system?
For starts.
Yes.
Yes. It's the first case. It's ideal cases because we have the time to work CADISS, and just the first step is to remove the fibrosis and put the mesna. And after, when the mesna works, I put the screw, I go to the opposite side. It's more and more minutes. It's good for the work for the mesna.
Okay, thank you. The second question is there samples for the test? So we have distributors of our CADISS system acting in the different national countries. So you can refer to your specific distributor to perform some tests with the CADISS system without any problem, of course. And we certainly encourage you to test this system. As we explained during the presentation, the learning curve with the CADISS system is very quick. So with 1 or 2 tests, you are quickly able to understand the huge benefits of this system in your revision surgery. Yes, and if you want to have any additional information or to contact us or to ask us to contact the distributor, you can just send a message via our website, website. The next question is the CADISS system also recommended to be used in cervical revision cases?
Yes, it's possible. It's not a problem. It's the same of the lumbar situation.
Yeah. In terms of a regulatory aspect, the indication allow the use in the cervical revision cases as well. The next question is, is there a patient with exclusion criteria for whom the CADISS system cannot be used? So if we are looking at the instruction for use of the system, the only exclusion is regarding to a potential allergy to the mesna or to any other thiol compound. Except this, there is no real exclusion criteria due mainly to the safety of the drug substance.
But the problem is if you have a dural tear when you use the CADISS, and with the potential contamination of the CSF, it's for me not a problem. You stop to use the mesna if you have a dural tear, but you wash with physiologic liquid and you close the dura. It's important first to close the dura when you have a dural tear. It's important to have no collapse of the dural sac and no bleeding of epidural vein, and to prevent infection and CSF and meningite. And after Valsalva test, it's okay. It's not a problem to use again Mesna.
The next question is how many days can you save in terms of hospitalization when using the CADISS system?
If you have no dural tears, you have a gain of 1 or 2 days.
Thank you. Another question, is the CADISS also useful to detach fibrotic tissues from the surrounding bones?
Yeah.
Yeah, I don't know if you have expertise with this.
Yes, it's the same of the implant, but it's easy to see around the implant and the titanium head of the screw, and it's the same for the bone, and it's easy to have a dissection between the bone and the fibrosis.
Yeah. And just to complete the answer of Dr. Triffaux, we have received some report cases of indeed a very good efficiency and performance of the removal of fibrotic from this bone tissue. The next question is, as it is a liquid Mesna solution that it used, how do you manage the contact time if it's not a flat contact surface to be dissected?
I have no time measure. Just I put the Mesna when I can at each step of the surgery.
So it's clear that to optimize the performance of the CADISS system, you need to guarantee this contact time between at the adherence or at the cleavage plane between the healthy tissue and the fibrotic tissue. In some application, some cottons impregnated with the Mesna solution can be used, but the best is really to have this flat contact surface.
And the time, it's more 5 minutes.
Yes, certainly. And the last question, so in which other neurosurgical indication could be the CADISS be used following your experience, peripheral nerves and tendons? I don't know if you have other experience with the CADISS system.
My only experience is for the spine surgery, but it's a contraindication in intracranial surgery, but it's no problem for this. And in my practice, I have no peripheric nerve surgery, but it's an indication in hand surgery on. It's not a problem.
So we have actually collected the first cases in hand surgery in Dupuytren's disease with a very good result actually in revision and in a primary case. And still one question. So which instruments are the most helpful to be used with the CADISS system? So in your practice, which kind of instruments do you use?
Just only the cannulate dissector to put the CADISS in operative field.
Still one. So is aspiration of the liquid in the surgical site not an issue to use the CADISS liquid solution? So if I can just comment on this, because it's an important aspect, is that it's important to guarantee again this contact time up to 5 or 10 minutes, depending on the density of the fibrosis. So it's important to avoid using, of course, the aspiration system to guarantee this contact time. So that's why usually there are two sequences of,
Yes.
of operation, but you can comment.
It's important to keep the product in the fibrosis, and with the revision case with instrument with a fixation, you work the CADISS when you put the screw, and it's often to have the time or to work the CADISS.
Yeah. Okay. Thanks a lot. I do not see. I do not see any more questions. So I suggest to close the webinar right now. Again, to thanks a lot Dr. Triffaux for his intervention and sharing his expertise. You can always contact us via our website, so do not hesitate. You will be able to review this webinar. We will put it on the website as well. So thanks again, everybody, for your attention, and I wish you a very nice evening. Thanks a lot.